Morning all. Asking a social scientist to speak in just 7 minutes is a hard ask, but I'll certainly try my best. In Zimbabwe, where I'm from, we have a beloved children's snack called Zappies or Mazapnex. And I remember visiting one of our participants in the Kids with Kids study in the maternity hospital. And the first thing she asked me was, "Did you bring me Zappies?" Mind you, this is a 12-year-old, and she held a tiny baby boy against her own small chest, and the other mothers who were in the ward, who were of an age where you would expect someone to already be a mother at, looked at her. Some looked at her with pity, but most shook their heads disapprovingly. I declare no conflicts of interest on the study, but I'll jump right into the background of the study and why we did the study. So this study emanated from another study that we're doing where we're investigating point-of-care STI testing among pregnant women. We started to observe that a lot of the participants who were coming through were under the age of 18, pregnant, and not registered for antenatal care, which I'll call ANC going forward. And this begged us to really look at the research and the data, and we realized that whilst there's been such a focus on prevention of adolescent, post-adolescent sexual reproductive health outcomes and HIV prevention, there are some blind spots that we're observing in terms of increasing early pregnancy and what happens to children when they get pregnant. And so we started to observe that there were some service and policy gaps, and we did this research to try and address some of those issues. We conducted our research. It was an intervention that we conducted in an area in Harare in Zimbabwe called Epworth, where it's largely informal settlements, high rates of poverty, and a lot of people there rely on foreign aid agencies. That is the MSF clinic that is there in Epworth. In terms of our research methodology, we formed an intervention study that we called Kids with Kids. With the support of the Ministry of Health and the Ministry of Social Development, we recruited 119 children. So in Zimbabwe, constitutionally, anyone who is under the age of 18 is referred to as a child, and that's why we use this terminology, because people who were eligible for this program had to be pregnant and under the age of 18. And we offered a comprehensive holistic package. We paid for their ANC fees. We provided obstetric and pediatric care, as well as many other tests, as well as birth kits and food hampers, taking in the vulnerability that a lot of these children were coming from. We collected quantitative data every time the children came for their routine visits, and we also collected qualitative data from 18 of the 119 children, as well as their next of kin, because we understood culturally pregnancy doesn't always happen in isolation, but they live within a social context, and we wanted to understand the social narratives around childhood pregnancy. And so some of these next of kin even included some of the fathers of the babies. We also recruited evidence from healthcare workers who were providing services to those children at a public health facility, as well as community care workers and counselors. In terms of our findings, similar to what Professor Tosca has already highlighted, we did find that at a lived experience level, most children were socioeconomically vulnerable. 63% highlighted that they grew up and they lived in food insecurity. And their parents, there was also a lot of generational poverty. Their parents as well had limited education. We even had some of their mothers who we interviewed being as young as 30 years old. Our youngest grandmother was 27 years old, showing that this was there was an intergenerational risk for early pregnancy. 79% had already dropped out of school by the time, before they even got pregnant, with 39% or 36% rather dropping out before grade 7. 20% then dropped out of school due to pregnancy, and from the sample that we had, only one continued with education. And these vulnerabilities became even more compounded once the children became pregnant. Most of the children that we have, over half, were kicked out from home and became residentially insecure. Culturally, there's a saying that when you get pregnant, regardless of your age, you need to go back to your husband or to your impregnator, or someone they call the owner of the pregnancy. In terms of knowledge about HIV, we found that a lot of children had been exposed to some level of comprehensive sexual education, and so they did know what a condom was, but then they didn't. There was a lack of translation of that ASRH knowledge. we found that only 10% of the sample that we had been diagnosed with HIV, but this had been vertical, and only 1% only one new diagnosis that happened horizontally. There were high rates of STI infections, with chlamydia affecting over a quarter of our sample. Contraception uptake prior to pregnancy was only as low as 3%, but this number jumped up at postpartum when they were now more exposed to antenatal care and were being actively linked for contraception all the way to 76%, with 91% of our participants preferring long-acting reversible contraceptives. So this highlighted that there was, in fact, a demand for effective family planning when services were made accessible. A lot of children that we had came in when they were already in their second or third trimesters, mostly because a lot of them highlighted that they didn't even know they were pregnant. They just could see that there were changings, but they didn't have a concept of what pregnancy was and if it was happening to them. Most of them as well, which was the lack of funds as well for booking fees, as well as being afraid to go to the facilities because of the infamous provider stigma that they were afraid to experience. In terms of our data set, we found that there was that aspect of adultification of children. So a lot of times when children become pregnant, they highlighted that they suddenly were being treated as adults. This was a 15-year-old who was in the postpartum phase, who highlighted that when she became pregnant, she was suddenly treated like an adult. She was expected to get a job. She had all these age-inappropriate financial responsibilities thrust upon her, and she said it was difficult being treated like an adult because she was unprepared for it. In terms of policy and legal constructs of childhood pregnancy, we found that a lot of pregnant children were classified as emancipated, and so they were removed from social welfare support. And so all these things happened at the same time and increased psychological distress amongst the children. I won't go into some of the recommendations that we then made from this research from a perspective of health systems, social care, and educational support, but I want to talk about what we have been doing going forward with the evidence that we got. We have been working nationally to form a network for post-conception policy enactment, where we've brought together a lot of NGOs that work, as well as policymakers, different ministries, to try and galvanize support for post-conception care policies. And this work is ongoing. We've been having meetings since last week, for over a year really, but we had some meetings last week and this week. We hope to start to document this regionally and share this evidence regionally, as well as at a local level through the use of what we call the art of health, which is a pooled art medium that we use to highlight social norms that put young children at risk. Thank you so much for listening to me, and I hope to be able to connect with you. You can scan the code to learn more about the Kids with Kids intervention.